Hello.
Hello, you're in the right spot. We're just about to get started.
Hello.
Hello, welcome. You're in the right spot. We're about to get started. Okay, welcome everyone. Thank you so much for finding your way to this lecture, whether you're joining on YouTube or over the phone. I'm Jasmine Chandy. I'm a program coordinator with Rush Generations. And we're going to start off with just a few upcoming programs and then go ahead and introduce our speakers. And for those of you who may be new to Rush Generations is a free health and wellness program that's aimed at aging as best as we can. So we offer lectures like this one, as well as workshops, exercise classes, support groups, volunteer opportunities, tons of great activities that you can get involved in. So we're going to highlight a few right now, as well as share a little bit about how you can stay connected. So, first and foremost, throughout the lecture today, if you have any questions for the panelists, you can leave them in the live chat box. So, if you're on the computer, it's going to be on the right side of the video. If you're on a phone or a tablet, it'll be under the video. So, throughout the lecture, feel free to add any questions or comments, and then we'll relay them to the speakers at the end of the lecture. We have our coping and connection in the time of COVID. This is a support group over the phone with a social worker. This will be on Wednesdays from 2 to 3 p.m. If you're interested in registering for this, you can call our toll free number at 800 757 0202. Next, we have our Senior Connections Friendly Caller program. So, if you're interested in having a volunteer call you once a week, just to have a friendly conversation, if you're feeling lonely or feeling isolated, this is a really good opportunity just to have a friendly conversation with a volunteer every week. So, if this is something you're interested in, you can call Patrick at 312 942 2089. Again, this would take place over the phone and you'd be connected with the volunteer to speak once a week. Next, we have our Take Charge of Your Health workshop. This begins next Thursday. So, Take Charge of Your Health workshop is a 6-week program. It's completely free and it's all aimed towards managing our chronic conditions. So, learning different skills, some problem solving methods, and figuring out how we can live a happy and active life. So, if you're interested in this workshop, you can register by calling 800 757 0202. And this will be taking place online through Zoom. If you haven't used Zoom before, if you have any questions, that's not a problem. As soon as you register, a member of the team will give you a call to make sure you have everything that you need and that you get acquainted with the Zoom before getting started. So, if you're interested in that workshop, that will begin on Thursday, August 27th and end on October 1st. And lastly, there are several more programs that we have. We've been able to move all of our programs virtually. So if you're interested in an exercise class, a support group, lecture, or any other program, or if you need to be connected to some sort of service or resource, we can definitely help you with that. You can call 800 757 0202. And if you'd like to sign up for our e-newsletter, this would be a good opportunity to receive an email with updates on our upcoming programs. You can type in bit.ly /Rush Generations. Once you type that in, you can just put in your name and your email, and you'll be on our list. So we're going to go ahead and introduce our speakers. We have a great panel today. We're really looking forward to this. We're going to start off with Dr. Raj Shah. Dr. Raj Shah has been a geriatrician at Rush University Medical Center in Chicago, Illinois for over 18 years. Currently, he is an associate professor in family medicine and the Rush Alzheimer's Disease Center. He completed his Bachelor of Science in Chemical Engineering at Northwestern University and then attended the University of Illinois at Chicago College of Medicine. After completing a family practice residency at West Suburban Hospital and Medical Center in Oak Park, Illinois, he received further geriatrics training at Rush. Dr. Shah's academic career interest is the design and conduct of community-based clinical trials for the prevention and treatment of age-related conditions, including but not limited to memory loss. He is a principal investigator for clinical trials in Alzheimer's disease. He shares information learned from research with diverse community groups in the region and by serving as a board member of the Illinois chapter of the Alzheimer's Association. With the support of Catch On, a geriatric workforce engagement program in Illinois, he also helps teach health science students and practitioners about dementia. Dr. Shah is a founding member of the Illinois Cognitive Resources Network, the ICRN, which works to optimize the cognitive and functional well being of Illinois residents and their families. Dr. Shah resides in Naperville, Illinois, with his wife and two children, one now a second generation student at Northwestern. He spends every summer hopelessly pulling out weeds in his garden and every winter dreaming about how to improve his gardening skills to achieve at least half of his mother's prowess in his lifetime. Dr. Poonam Marai is a geriatrician at Rush University Medical Center in Chicago, Illinois for the past 5 years. Currently, she is an assistant professor in internal medicine and practicing at Rush Senior Care. She completed her Bachelor of Arts in Philosophy at the University of Illinois at Chicago and studied Buddhism and death and dying in India. She completed her internal medicine residency and geriatrics fellowship training at the University of Chicago. She also spent a year in Guam as a hospitalist working with Indigenous islanders. Dr. Mariah enjoys teaching learners such as medical students and PA students and is the assistant program director of the Geriatrics Fellowship Program. Dr. Mariah enjoys keeping up with her two young children and bringing knowledge about older adults to the community through social media like Instagram and Twitter. And it sounds like there's a little noise, so I'm going to go ahead and mute that. All right. Next, we have Teresa Washington. Teresa's professional life combines years of community work with her passion for health disparities research. She currently serves as a research study coordinator for the Rush Alzheimer's Disease Center. Teresa is part of the outreach and education team, as well as the emerging qualitative study team. She is also the coordinator for Geriatrics Workforce Enhancement Program at Rush. Teresa received her master's degree in community health education from the University of Illinois at Urbana-Champaign. She is currently a doctoral student in the College of Nursing at Rush University. Teresa has been with Rush Alzheimer's Disease Center since 2014. Last but not least, we have Susan Frick, who has worked at the Rush Alzheimer's Disease Center since 1997. She coordinates dementia-specific training programs for healthcare professionals, helps coordinate the Dementia Friendly and Dementia Friends initiatives, and presents both locally and nationally. Susan is the director of Without a Warning, a support program for individuals and families who live with younger onset Alzheimer's, and the executive producer of the documentary created by the group, now airing on PBS, entitled Too Soon to Forget: The Journey of Younger Onset Alzheimer's Disease. She works with patients and families in the Rush Memory Clinic and with people involved in the Rush Alzheimer's Disease Center research studies. Susan received her master's degree in social work from Loyola University of Chicago and has worked in the field of Alzheimer's disease since 1987. So we'll go ahead and give our lecture speakers a warm welcome, and we're going to begin with Dr. Shaw.
Oh, thank you, Jasmine, and really a warm welcome to everybody on the presentation today. Really appreciative of you taking time out of your busy schedules to spend some time with us and to share in the learning and experience around something I feel really is an important aspect, which is how do we help people living with or at risk for developing Alzheimer's disease and related dementias to thrive not only personally, but with their families and with their communities. And my hope was to provide some just background information about what we're seeing or anticipating to see in Illinois regarding Alzheimer's disease. As mentioned by Jasmine, I trained in family medicine, and I always mention to people that in many ways, Alzheimer's disease is a disease that impacts families. It not only affects the person, the people that they are closest to in engaging and working with as informal caregivers and supporters, but then also it reverberates out into the community and in the engagement of the person with their community surroundings. And Illinois is one of the states which has a very large population. We have over 12 million people that reside in the state of Illinois, and about 1.2 million are over the age of 65. And with the baby boom generation coming through in their late 60s and early 70s, over the next 30 years or so, we will see an increase in the number of older adults in Illinois, and although there are young people who will develop Alzheimer's disease and related dementias, the majority are individuals that are over the age of 75, and definitely the higher risks of not only cognitive difficulties, but functional and social needs increase as people approach above 85. And our best estimates by the Alzheimer's Association are that in the state of Illinois, we have about 230,000 individuals with Alzheimer's disease. Now, we anticipate that maybe only about half of them have been formally diagnosed and know that they have Alzheimer's disease or related dementia. And some of the work we have to do is just to continue to educate about the importance of recognizing when symptoms are present, of having memory and cognitive difficulties, and then seeking help and support to understand what those issues are and not just taking them as part of normal aging. And with the growth of the population, we anticipate that even in 5 years, the number will go up by about 30,000 individuals. And the way I try to put it in perspective is that I live in Naperville, and when I look at the sign about the population of Naperville, it's about 154,000 people. And it's the 6th largest city in the state of Illinois. And it just makes me wonder, right? Like 230,000 individuals, they would be the 5th or the 4th largest city in Illinois if they were all together in one space. However, we know that's really not the case, and people are spread out in multiple communities that are experiencing these symptoms over time. So with that, Jasmine, I'm going to go down on the slide that it not only affects the number of people and the growth, but the caregivers, people who sometimes don't even think of themselves in that role because they're a family member, they're a spouse, they're a daughter, a daughter-in-law, son-in-law, son, grandchildren, cousins, aunts, uncles, nieces, that all pitch in when somebody's having troubles with cognition to help the person maintain their quality of life. And we estimate that, for the 230,000 individuals, there's about 587,000 caregivers, informal caregivers that are involved. And they provide a staggering amount of numbers of hours of unpaid care to support people that are living with dementia and and with the most common one being Alzheimer's disease. And so there's a large amount of resources and energy and effort spent to just help to maintain people, and they're always not fully recognized. And if one thing we can do is to just encourage people to recognize the caregivers, to support them, and to show that they also are valued and given the help and abilities to maintain their own well-being also. And then I want to come to a final point on this sheet, which is how are we going to handle this? If there's 230,000 individuals in the state of Illinois that have Alzheimer's disease, if we anticipate that it will just be trained individuals that go on for extra training and taking care of older adults, we're not going to be able to serve the caregivers and the people that develop dementia to our full extent. Right now in the state of Illinois, we estimate there's only about 218 physicians who take extra training after completing a family medicine residency or an internal medicine residency to go on for extra training and taking care of older adults. And really, you would even almost have to double this number to be close to helping to support the other physicians, including primary care providers, neurologists, psychiatrists, to help support people that have dementia over time. Luckily today, we have the opportunity to listen to one of the geriatricians and her experiences to go through what that process is like for an evaluation. And Dr. Poonam Marai will take over and lead us through those discussions. And then we'll follow up after Dr. Marai with a discussion with Tarisha Washington and Susan Frick, who will then lead us to what's beyond just the healthcare system in supporting somebody with dementia and having the entire community be part of the discussion and support through Dementia Friendly Illinois and Dementia Friends Illinois programs. So I really appreciate your time and energy and being engaged with this, and I'll turn it over to Dr. Marai. Thank you again.
Okay, great. All right. So again, my name is Dr. Marai, and I am a practicing geriatrician. I do want to take the time to just thank Rush Generations for allowing me to share in this forum and to talk about a topic that's really important to me, and that's dementia and memory loss. So Dr. Shaw mentioned, what is a geriatrician, and or that there's not many of us, but what exactly do we do? And I take care of patients, am their primary care provider, but I also am taking care to pay special attention to syndromes that affect older patients, one of which is dementia and memory loss. And so we take care of patients in the clinic setting, in the office setting, on the hospital side. So if a provider in the hospital is saying, I'm not sure how to handle this syndrome that's affecting this older patient, we provide help there. And we also take care of patients in the nursing home. And I work with an amazing team, a team of nurses, advanced practice providers, social workers, psychiatrists, therapists such as physical therapists, occupational therapists. And I really want to underscore the importance of the interdisciplinary team that I work with. Especially when treating a disease like dementia, it really takes a village. It takes a village for the patient in terms of the caregivers, but also a village, a team of people helping on the medical side. So I do want to step back. Whenever we talk about a syndrome that affects older people, I always like to step back and think about what are the biases we have around aging. because that's going to affect how we view this topic. In fact, it's going to impact how a patient views themselves, how society views older patients, and even how we allocate resources towards older adults. So I want to do this quick exercise before we get to the meat of the information. So I'm going to flash a word on the screen. The word is old, in case you're calling in. And when you see the word old, I want you to take 10 seconds and just observe your mind and to see what terms come to mind when you see this. Try not to filter. I'll give you about 10 seconds. Okay. Now I'm going to put a different word on the screen. And in case you're calling in, the word is elder. I want you to take about 10 seconds and any word that comes to mind, jot it down or just make a mental note. So when I've done this exercise with medical students, with young people, and even with older patients, my patients, the bias really becomes clear. When we hear the word old, it's such a loaded term. I've heard terms, people, when they see the word old, they think decrepit, they think obsolete, they think decaying, problems, breaking down. But with elder, words that come to mind are things like wisdom, vibrant, guide, resilience. So imagine if you live in a society where we're using words like old to describe things that are related to dementia, memory loss, just beware that there's heavy connotations that come with just even our word choice. And so, I have a graph up on the screen again for people that are, calling in. It's a graph. Oops. It's a graph, with age on the x-axis. And there's basically a line that goes down as age progresses. It's a downward sloping line. And you might ask, okay, so, what's on the y-axis? And really, this is how people view age. What's on the y-axis? It's anything, it's everything. It's function. We think that function goes down with age. Mobility, we think that mobility goes down with age. Cognition, we think that cognition goes down with age. Resilience, utility in society. So imagine living in a society where this is how aging is viewed. And this is really what our elders are up against. Not only that, many of our elders actually have some of these views about aging as well. And studies have shown that if you do have this viewpoint about aging and looking at it in a negative way, it can actually shorten your life. In fact, about 7.5 years. And that's for various reasons, whether it's making poor health choices, maybe it's not addressing screenings that are recommended, maybe it's depression. So when we look at something like cognitive function, we need to be aware of what's normal and not make assumptions that just because you're getting older, you're going to have memory loss. So let's take a moment to just briefly, describe what is normal memory loss. And again, even if we look at that term, memory loss, we're already framing it in the negative. I prefer to use the word memory changes. Memory changes as you get older. That is a fact. And so, let's talk about what's normal memory change. And if I go back to normal memory loss, that's just because that's what we tend to use often. But so normal age related memory loss, it doesn't prevent you from living a full life, from living a productive life. For example, you might occasionally forget a person's name, but maybe remember a little bit later in the day. You might misplace your glasses, or maybe you just need to make lists more often than in the past to remember appointments or tasks that you need to do. So these changes in memory are generally manageable. They don't disrupt your ability to work, your ability to live independently, or your ability to maintain a social life. So that gets us to the word dementia. What is dementia? So dementia is an umbrella term. It actually encompasses many types of pathologies, and we'll get into some of those specifics. But it's an umbrella term that's used to describe a set of symptoms. And it can affect multiple parts of your cognition. It's not just memory, although memory is one part of your cognition, but dementia can also affect your reasoning, your judgment, your language, and your thinking skills. And dementia tends to start gradually and get worse over time. And it can impair your ability to work, to have social interactions, to have relationships. And so often, memory loss that disrupts your life is one of the first or more recognizable signs of dementia. And we'll kind of, this is a good chart here to describe what are the different signs that you might see. So, asking the same questions repeatedly, saying, what's the date today, or what's the plan today? Being told the answer and then repeatedly asking that throughout the day. Forgetting common words when you're speaking. Mixing up words, so maybe saying window instead of door, or bed instead of table. Taking longer to complete familiar tasks. So for example, maybe following a recipe was very easy before, but now it's a little bit more challenging. Or maybe the steps needed to pay a bill are more challenging. Misplacing items in inappropriate places, like putting your wallet in a drawer or putting your keys in the refrigerator. It can be getting lost while walking or driving in a familiar area. I had a patient who presented after she ended up driving on 9094 and ended up in Wisconsin when she was just trying to travel locally in Chicago. And the problem is after several hours, she still hadn't recognized I'm in a different state. So that's a red flag, getting lost in familiar areas. And then having changes in mood or behavior for no apparent reason. So as we're talking about memory, I want to first, this is a common question that I get from a lot of my patients. How do I protect my memory? And this is really a multifactorial approach. We approach this in many different ways. So let's go through those ways. So the first is sleep. It's important to have good sleep if you want to maintain your memory. And so you might ask, okay, well, how many hours should I get? And that really is variable. It depends on the person. But let's throw out maybe 7 hours or so, give or take a few hours. You really want to ensure that you have good sleep hygiene. So, we really want the bedroom to be used only for sleeping. We want to make sure that you're not using devices in your bed. That light from the devices can stimulate your brain and make it more difficult to sleep. You want to make sure that the room is cool. You want to avoid caffeine. I've had patients that drink caffeine up until 8 p.m. at night and have difficulty sleeping. Caffeine is a stimulant. You want to make sure that you empty your bladder before bed. And unfortunately, with some of our older patients, especially our older male patients that have an enlarged prostate, they end up urinating a lot. So you want to give yourself the best shot at a good night's rest by making sure your bladder is empty by the time you get to bed. And then we want to treat any issues that affect sleep, like OSA or obstructive sleep apnea. It's important to get that diagnosed by a doctor and then to wear the right device at night to ensure that you're getting oxygen and good airflow. Then you want to make sure that you're eating healthy. And I really want to put special attention on a diet called the MIND diet. MIND stands for the Mediterranean Intervention for Neurodegenerative Delay. It's a diet that was actually developed at Rush, and it specifically focuses on brain health. And it discusses 10 food groups that are emphasized. So the first one is all vegetables. So you should try to have a diet full of vegetables, but not only that, it puts special emphasis on green leafy vegetables. Then there's berries, raspberries, blueberries, nuts, and in general, it doesn't specify what kind of nuts, but we know in general that walnuts are better than peanuts. Olive oil, to incorporate that type of oil over other oils, whole grains, fish, beans, poultry, and wine. And my patients really like that last one, the wine. And they really do, emphasize 1 glass of wine or less, and potentially favoring red wine over other wines because of a substance in there called resveratrol that is thought to help prevent Alzheimer's disease. So with that, having good sleep, eating healthy, and then you want to make sure that you control your chronic diseases, your diseases like diabetes, cardiovascular disease. So that's working with your primary care doctor so that for your diabetes, you bring that A1C target down to whatever is agreed to, making sure that things pertaining to your cardiovascular health, like your cholesterol, your blood pressure. There's been recent data coming out from the SPRINT trial, which showed that we actually, even in our older adults, want to target a systolic blood pressure, that top number of your blood pressure, as close to 120 as possible. And so we want to make sure that you're on all the right medications to control your cardiovascular risk factors. You want to keep learning. We saw that graph, right? That's downward slope. That's what society is telling you that getting older is like, but that's not the truth. Our older patients, they can learn a new language, they can learn a new hobby, they can learn a new sport, or engage in volunteer work. Keep learning. That isn't so important for the brain muscles, so to speak. You want to stay physically active. And so how much is physically active? We're talking about 150 minutes of moderate aerobic activity. So that's activity where, if you're talking to someone, you're breathless. So like brisk walking, so 150 minutes of that a week, or about 75 minutes of vigorous aerobic activity like jogging. So you want to maintain physically active, and then you want to maintain social interaction. Having social relationships is very important for your brain health, and it's been very difficult in the time of COVID-19 to do this in a safe way. But social interactions help ward off depression, they help ward off stress, both of which can actually contribute to memory loss. So you really want to look for opportunities to get together with loved ones, with friends and others, especially if you live alone. So let's briefly talk about some memory strategies that you can use. So first, writing it down, using whatever works for you, whether it's a calendar, the notes function on your phone, Post-it notes in your house, planners or checklists. There's a reason that pilots and surgeons use checklists. It's a way to not forget anything. And so I suggest using checklists to make sure that you've done specific activities. Association, so relating new information to something that you already know. Using things like repetition. The more that you repeat and you write, you say things over and over again, you're putting that information from your short-term memory and storing it into your long-term memory. And as we know, dementia affects our short-term memory. And so if you can store it in your long-term memory, you're more likely to hold on to that longer. So repetition is very important. Visualizing. If someone tells you to remember 3 words, it's one thing you could repeat those words, but you can also visualize those words in your head, and it helps to consolidate that information in your brain. Categorization, so linking items together. If you're trying to remember a long shopping list, for example, instead of remembering every single item, maybe it's just categorizing them. So you know that you need 3 different fruits on your list, you have 3 different vegetables on your list. That can help you remember. You want to talk it out. Saying things out loud also helps to store things in your brain. Using cues, and these cues can be visual, so something that you see, like those Post-it notes. They can be auditory, like alarms or certain music, for example. Or these cues can be tactile. I have patients that will wear a rubber band on one wrist and then switch that rubber band to a different wrist when they're trying to remind themselves of something. You want to have set locations. So you want to put common items in set places. This is kind of the idea of Kaizen, having a system in place so that when you walk in, you place your keys here, and then you do X, Y, and Z. That system helps to help you remember things. And then routine. When you have a routine or a habit, you rely less on your memory. So this is where I have, for patients that maybe forget to take their medications, put that somewhere in your routine. Put your pill box right next to your toothbrush. Because if you're brushing regularly and it's part of your routine, seeing your medications right next to your toothbrush will remind you. It'll be incorporated into your routine, and you'll have less chances of forgetting to take your medications. So routine is really important for older patients, younger patients, and especially for patients that have memory issues. So then, let's say you feel like maybe you're having some memory issues, you're concerned about something. When should you seek help? Basically, if you have the concern, that's enough for you to go ahead and see your healthcare provider and have that discussion with your healthcare provider. There are tests to determine the degree of memory impairment and to help diagnose the cause. So my recommendation would be that if you feel concerned about your memory, or if you have a loved one that's concerned about your memory, perhaps it's best to bring it up to your healthcare provider. And so that gets us to, how do we make the diagnosis of dementia once you come to our office? And the first thing is we need to talk. We need to talk to you. We need to ask you plenty of questions, but not only just of you. We're going to ask questions from a family member, someone that's maybe observing you day to day. And questions that we'll ask you are, when do you feel like your memory concerns began? What medications do you take? This is including all the prescription drugs that you take, but also those over-the-counter medications or those dietary supplements. We want to know about that too. And so we'll ask you which ones you take, what doses do you take? Have you recently started a new medication? That can affect how we think about your memory loss. What tasks do you find difficult? Is now paying your bills more difficult? Is bathing more difficult? What of your everyday activities are you finding more difficult? What have you done already to cope with your memory problems? Do you already use a Post-it note system or a list system? How much alcohol do you drink? Alcohol can play a role in your memory depending on how much you drink, how long you've been drinking. Have you recently been in an accident? Have you fallen or injured your head in any way, kind of hinting at some type of traumatic brain injury? Have you recently been sick? We're going to ask you about your mood. Do you feel sad? Do you feel depressed? Do you feel anxious? Have you had any major changes in your life, a major loss, a loss of a spouse, for example, a loss of a parent, a major change in your life? Are you now celebrating retirement, or have you been laid off? These are really important questions for us because it is often at these major changes, life changes, where we start seeing some cognitive issues. They may have not surfaced because you were going to work every day, you had that community at work, but now that you're at home, some of these memory issues are starting to surface. And so after we do that extensive questioning, we're going to do our physical exam. We're going to examine you. And part of that is doing a very thorough neurological exam. And then we may or may not order blood tests or do brain imaging, depending on the story you've given us, what we're seeing on your exam. We may refer you to get some cognitive testing. We can do some basic testing in the office visit itself. Screening tests for example, the mini mental status exam or the Montreal cognitive assessment exam. Or we can send you to a neuropsychologist who specializes in this type of testing. They'll do hours of testing to help us figure out what part of your cognition is affected. And then if you're seeing a primary care doctor, then you might be referred to a specialist like a neurologist, a geriatrician, or even a geriatric psychiatrist. And so all of this together is helping us to make the diagnosis of dementia. Now, I wish there were blood tests that we could just do because what we're doing is piecing together everything that you're telling us, everything we're seeing on exam. We might do some blood tests, all of that. I wish we just had this magical blood test that could tell us that you have dementia. And I will say in the past few months, there has been some buzz about blood tests that may be able to help us diagnose Alzheimer's dementia. But those are not being used on a day-to-day basis at this time. It's all in the research phase. And so we have to use what we see in the clinic to help make the diagnosis. Now, why is it even important to make a diagnosis? Well, we do have treatments to help manage some of the symptoms of dementia. But more importantly, the diagnosis helps us begin the journey of educating the patient, but also the loved ones about the disease. And it's about planning. It's about determining what future care preferences a patient might have. It's identifying care facilities or at-home care options for you, and also settling any financial or legal matters while you have your cognition intact, so that these issues don't come up later and you're taken advantage of. And there are lots of resources out there. There's excellent books. One that I'll just mention right off the bat, The 36-Hour Day. There's also the Alzheimer's Association, which is a fantastic resource. And we'll talk about some of the resources later in our presentation today. And also the internet, give or take, there are lots of excellent resources out there to learn about the disease you have and to help manage it. So I want to briefly talk about the different types of dementia. Again, dementia is an umbrella term, but there are actually different types. And so let's go through each one. So Alzheimer's dementia is the most common, and it relates to the specific proteins being deposited in your brain. Specifically, there's beta amyloid plaques and tau proteins. And these cause changes in your brain structure, and that affects your brain function. And usually the first symptoms we start seeing is short-term memory changes. And if that's mainly in the beginning. But otherwise, patients are able to talk, their level of consciousness, their alertness is usually normal. We don't tend to see any findings early on when we examine you. And the onset of Alzheimer's tends to be very slow, very gradual. If it's not, then we actually question the diagnosis of Alzheimer's. However, sometimes, as we talked about, if there is a major life event, like you've just retired or you've lost a spouse or a child or a parent, sometimes the onset may seem sudden, but that's really just unearthing symptoms that may have been missed before. And the onset is usually after 60. If it occurs before 60, again, we're questioning the diagnosis, or we're looking at early onset dementia. And the typical course of dementia is usually over 10 years. Then we have vascular dementia. This is the second most common type of dementia, but it actually overlaps with Alzheimer's dementia about 30 to 50% of the time. And this can also be gradual in onset, or it can be stepwise. In other words, you're doing fine, and then maybe you have a stroke or some type of cardiovascular event like a heart attack, and then your cognition falls. And then you stabilize again, and then something else happens, your cognition falls. So we call it a stepwise decline. And so memory impairment may not be the first symptom that we see here. We may suspect vascular dementia in someone that's had a stroke, for example, that's starting to demonstrate cognitive issues. And usually on our examination of the patient, we tend to see an abnormal neurological exam. And so in this case, it's helpful to sometimes get brain imaging with a CT or an MRI, and sometimes neuropsychological testing. Those battery of testing can be helpful as well. The next type of dementia is called Lewy body dementia. This is another type of dementia that involves a deposition of a protein in your brain. And different from Alzheimer's, in Lewy body dementia, we see a lot of fluctuations in someone's alertness. Maybe at the beginning of the day, a patient's alert, awake, but then several minutes later, they're not awake and alert, and that changes throughout the day. We don't see as much of that with Alzheimer's as we do Lewy body dementia. And these fluctuations can be very, very quick. It's very, in terms of good and bad days, with Alzheimer's dementia, you'll have good days, you'll have bad days, but these are more dramatic with Lewy body dementia. We oftentimes see hallucinations, visual hallucinations, so maybe seeing animals that aren't in the room, maybe seeing family members in the room that aren't there, or that have maybe passed away. We don't see this as much in other dementias, or we see it kind of at the end stages of other types of dementias. We tend to see Parkinson's features here. So maybe a tremor, maybe more shuffling, walking, difficulty with balance. So we pick up a lot of this on the neurological exam that we do. And then if we sometimes, a way that we can test Lewy body dementia is if we give certain medications like antipsychotic medications, patients don't react well when they have Lewy body dementia, and that's a clue to the diagnosis. And finally, I want to talk about frontotemporal dementia. And this is a group of disorders with that affect the front and the side parts of your brain. Again, it can be slow, gradual, but we tend to see it early on. So in patients in their 50s and 60s. And because of where it affects the brain, when it affects the frontal parts of the brain, we tend to see a lot of personality and social behavior changes. Patients have a really difficult time planning things. They're very impulsive, so they might just start spending their entire life savings. They might make these grand purchases for no reason. They might have this sense of apathy towards problems, other people. And if they have issues with the temporal parts of their brain, it'll affect their language. They'll have difficulty getting their thoughts across. They'll have difficulty recognizing people, recognizing objects, and we tend to see this earlier on in the disease. So their memory may be okay, but it's their language, it's their personality changes that happen. This can be very, very difficult for caregivers to handle. And then this tends to have more rapid progression than Alzheimer's disease. So I mentioned the 10 years for Alzheimer's. Here we're looking at 4 to 8 years in terms of prognosis after a diagnosis is made. So, once we do make the diagnosis, how do we treat the memory loss? And I think this is perhaps one of the most important slides in my presentation, because it underscores the fact that medications are just one aspect of managing this disease. And I'm saying managing this disease. I wish I could say cure, but there is no cure for dementia. And so really we're just managing. So we use medications. Common ones include memantine or donepezil. But in addition to medications to stabilize the memory and the disease, we are also usually treating depression that might happen with dementia. So we'll use antidepressants. And then at times, there's a lot of agitation that patients might have when they have dementia. And so although we always try to use behavioral interventions, we sometimes have to use antipsychotic medications to help calm a patient. That's not preferred, but in case we do, oftentimes if a patient is a harm to themselves or to others, we sometimes have to use those medications as well. But that's just the tip of the iceberg. If you can see below medications, there's also social services, which is critical. Once a dementia diagnosis is made, it's important to hook the patient and the family up with resources in the community and making sure that there is that support network for them. And then there's education, which maybe arguably is the most important way to treat the memory loss. How do we set up, well, first of all, how do we help educate the patient and the family about the diagnosis, what to expect? How do we set up your home if that's where you want to age there? How do we set up your home so that it's a safe place for you? How do we talk to a patient that has dementia? We are oftentimes counseling caregivers that this is not about winning an argument. So if your loved one is saying, oh no, it's March of 1985, there may not be a reason to correct them in this case. Sometimes it's best to just go along with things. So we coach patients and families about how to communicate with each other so that there's not this constant tension, because this can be very frustrating for caregivers. So again, medications are just the tip of the iceberg. We're really looking at how do we hook you in with social services? How do we help you age in the place where you want to age in? And how do we educate you about the disease? And I will tell you that oftentimes a primary care doctor's office, that visit is short. So this education may not always happen in that setting. And that's where we're relying on our interdisciplinary team and maybe offering resources like books and resources online to help the patient and the family get educated. So I briefly talked about, where do you want to age? And that becomes a very important question for patients with dementia. There's lots of options. So for example, home, maybe a relative's home, assisted living, nursing home. Maybe you want to actually, maybe you're from a different country and you want to age in a place back home or abroad. Maybe you want to age alone in your own home. Maybe you want to do it with siblings or relatives, with children. But I just want to highlight the fact that only about 4% of older adults live in nursing homes, and only about 2% of older adults live in assisted living facilities. So most older adults are living in the community. And I'll say that 90% of seniors actually want to be in the community. They don't necessarily want to be in a nursing home or an assisted living facility. So we have to work with our social workers, with the resources that you have, to figure out what infrastructure is available. And we have to consider, if your home has, 2 flights of stairs, that may not be a long-term option, or we may have to modify your home so that that is an option. We need to make sure that if you do pick home, that we have the right caregivers for you at home. Dr. Shaw mentioned how much of family do the unpaid caregiving. And if maybe you live alone, if you need to tap into paid caregivers, they're not necessarily cheap. We're looking at about $20 an hour or in that ballpark. So that can add up. We need to make sure that you have transportation if you need to get to appointments or you need to get groceries, et cetera. So we need to consider all those things as we're trying to figure out where is the best place for you to age. Keeping in mind also, how all of these things are paid for. So I mentioned the private caregiver, but assisted living, this isn't covered by Medicare. And so, the average cost is about $4,000 a month, depending on the facility, it may be more. And so long-term care insurance can cover it, but not many people have that. There's also nursing homes, as we talked about it, but again, this isn't covered by Medicare, and the average cost is about $6,000 a month. And so oftentimes people have to tap into other resources like Medicaid to get it covered. So I just want to underscore the importance of planning with your family to make sure that the setting you want to be in is honored. And a lot of that is about planning. So I want to talk about some barriers to dementia care. As Dr. Shaw mentioned, a lot of dementia is undiagnosed. So it's a lack of self-awareness of the disease process, either because you write off a memory change as just normal aging, or maybe you're not seeing a doctor regularly. There's limitations to seeing doctors regularly. Perhaps there's a fear of a diagnosis. There's a lot of stigma about going crazy, and thanks to media or other places where we stigmatize having mental illness or having cognitive issues. On TV, we'll see someone that maybe is institutionalized and is placed in front of a TV drooling. That's not necessarily what these facilities look like. There's a lot of stigma about going crazy, and so if you have that stigma, you're not going to try to address the underlying issue. Again, some of it is assuming that some of these changes are just normal when maybe there's some red flags. Also, just ability to access care services, and we'll talk about that briefly, but these care services may be available in your area. Maybe you don't know about it. Maybe there's issues with price. So all of that has to be considered. And this is sometimes where we have our patients work with a social worker to assess, what's available. And then, the ability to afford the diagnosis and the treatment. And I'm not necessarily talking about, the ability to pay for the medications. These medications have been out there for a while. They're relatively cheap, but I'm talking about, the hiring of the caregiver, the, maybe the money that's needed to pay for a nursing home or an assisted living. That's where a lot of the cost comes into the caregiving aspect of dementia. Not to mention, I think COVID-19 has now been a barrier to dementia care. A lot of the resources that our patients had, like adult daycare services, memory cafes, support groups, a lot of this has been shut down or it's been limited. Older adults have been limiting in-person visits, so having family members visit. I've had patients that will just have their family members drop groceries off on their porch. And so that limited social interaction is really a barrier to dementia care. Disruption of routine. COVID has disrupted our routine. And as we know, routine is critical for patients that have dementia. It's the way that they get through their day. The Alzheimer's Association, they have a 24-hour hotline. They reported during COVID an increased number of calls of caregivers that are overwhelmed. I've been very worried about a lot of my, the caregivers for a lot of my patients. You know, they may have, caregivers may have relied on other people during non-COVID days to kind of step in, maybe give them a break, but now they don't have these support systems available. And so there's a lot of caregivers that are starting to get burned out. There's been the issue of wearing masks for a lot of our dementia patients, especially with more advanced dementia. They have a hard time keeping that mask on their face. And then, you know, so much of our life has changed to the computer. But if you have dementia, there's difficulty with the visual spatial skills in using a computer, or even the attention needed to have a Zoom call with loved ones. And so that's presented a barrier to those social interactions. And then not to mention, you know, when a patient comes to their primary care doctor, you know, there are these longitudinal relationships. We get to know our patients well. Well, when a patient comes in to see me, we talk about family, and there's a way that, you know, patients can compensate for some of their memory issues. They may be embarrassed to bring it up, or they may just have other issues that they want to talk about, with memory being the last on their list. And so with a short visit with the doctor, it's hard to get to some of those issues. And the other big thing is patients maybe not bringing loved ones to their appointment, or caregivers to their appointment. And so without that collateral information, sometimes it's really difficult to know exactly what's going on in a patient's day-to-day life. Patients sometimes will present themselves in the best light to their physicians or their healthcare providers, and they may not, you know, want to discuss some of those memory issues. But it's really important, based on all the symptoms that we talked about earlier, some of those red flag symptoms, if you have those, to bring that up to your doctor, or your healthcare provider. They are your ally. And even if, you know, we can't get to it at that visit, we will absolutely make that the agenda for the next visit. I want to also talk about end of life discussions. You know, I feel like we tend to tiptoe around the topic of death, but as we all know, there is that inevitability of death. We're all going to die, so best to be prepared. And so here's a list of some documents that can help you die on your own terms and not ours. I've had a lot of sad patient stories of deaths in the intensive care unit, maybe with children fighting, disagreeing on how best to address the end of life of their loved one, or maybe even having interventions done to a patient when, because it wasn't written down anywhere, it's just the default in the medical system. And so it's really important to have all of these documents in place and to have these discussions in place. So first is a living will, which is a written legal document that spells out medical treatments that you would want and that you would not want to help keep you alive, as well as it spells out preferences for other medical decisions like pain, organ donation, etc. There's also the POST, or the Provider Orders for Life-Sustaining Treatment. This is what we call the DNR form. Although on this form, you also specify, you specify whether you do not want to be resuscitated or you want to be resuscitated. And that basically means, in the case of an emergency, if something were to happen to your heart or your lungs, would you want resuscitation? Would you want chest compressions, a shock, electrical shock, and a breathing tube to try to bring you back? And perhaps depending on where you are in your dementia diagnosis, depending on your maybe religious or spiritual beliefs, depending on your beliefs in general, you may or may not want those things. So this document is to help put down those wishes. Then there's the healthcare power of attorney and the financial power of attorney. And basically, these are durable power of attorneys, meaning that these stay in effect if a person is unable to mentally or physically make decisions. And this is really important. This has come up multiple times in situations where maybe a patient has not designated a healthcare power of attorney. So there is a list of a surrogate decision maker that the state of Illinois has provided us. And that, if we go by that list, that may not be your preferred person, But by law, because a healthcare power of attorney form was never made, we have to defer to that person. And it can get kind of tricky. Sometimes we've had to resort to talking to an adult child that maybe a patient hasn't talked to for 20 years. So it's really important when you are of sound mind to have these documents in place, to have a healthcare power of attorney form in place. Also financial power of attorney. We tend to see with dementia that there's a lot of financial abuse. And so you want to have someone that you trust making financial decisions for you, and that needs to be written down. That typically needs to be done with a lawyer versus a healthcare power of attorney that you can do in your clinic visit with your provider. We can get that done, give you a copy, scan a copy in the healthcare system, and you're done. The financial power of attorney you would need to access an attorney for. And there are lots of resources out there. There's websites. So for example, there's one called prepareforyourcare.org. There's this document here that I have on the left on the right, called the 5 Wishes. And it's a document that you go through and it asks questions, and tries to hone in on what are your preferences. And based on your preferences, it helps you fill out some of these documents. And I will say that, as with patients that have memory loss and dementia, they tend to interact with the medical system more. We have found with studies that patients that have dementia tend to be hospitalized more. They tend to have more emergency room visits. So these documents are very important to guide the care that is provided in the hospital. I'll never forget a patient that I had that wasn't being seen at our hospital. She was basically had called her doctor or her healthcare system over 10 times, had been in the hospital, had been in emergency rooms over 10 times in the year. And at no point during that time did her dementia come up. And then she eventually ended up getting hospitalized at Rush. And because at Rush, we're an age-friendly health system, part of what we address are the 4 M's. So that's medications, that's memory, that's mobility, and what matters. And so it was brought up that a lot of her being in and out of the hospital was because of her memory issues. And so we were able to get her the right resources, the right infrastructure at home so that she's not going in and out of the hospital. And so, I'll just underscore again that a lot of these end of life discussions we tend to tiptoe around, but these are discussions that are best had at the beginning. Honestly, it's when you're at your healthiest self. And as life changes, maybe you do develop a dementia diagnosis, you can revisit any of these documents and make changes. And so to revisit these documents often. So with that, these are some resources or references that are used that I would point you towards. And I'll leave my contact information here. If you have any concerns, I definitely recommend reaching out to a geriatrician or the Rush University Senior Care, where we address memory loss and dementia. So with that, I'll hand it off to the next speaker.
Okay, thank you so much. And I was going to do a screen share too, so I don't know if we should take yours down. There we go. Let me just get it started here. Great. So thank you. My name is Susan Frick, and we are going to, and Tricia and I are going to tell you a little bit about a program that we're involved in, and us and several other people through Rush and through other centers throughout Illinois, because we just heard this wonderful overview of what dementia does and how it has an impact on caregivers and on the person themselves. And so Tricia and I are involved in a program called Dementia Friendly Illinois, or Dementia Friendly America. And what this program is looking at is what dementia does to the family unit, to the person, and how this is really a often lonely experience. And as thinking about what we just heard with COVID, we're all probably feeling a little lonely right now. But with dementia, that's a way that they can feel a lot of times. And so this program is really looking at what we can do on a community level and what we can do as an individual. So it's dementia friendly and dementia friends. And so we'll tell you, Trish and I will tell you a little bit about each. And I've worked at the Alzheimer's Center since 97 and help run a support group for people with young onset Alzheimer's disease. So that very unusual younger person. And so a lot of what I'm going to just tell you about is things I've heard from that group. We've had that group going for 16 years. And I've heard that from both the person living with dementia and from the family members of how isolating it can be to live with dementia. And so what we're hoping in just this conversation, what we're sharing is if you're a person, that one thing we'll show you is how to become a dementia friend. You sign up online, it takes just a few minutes, and we'll tell you about that program. But also to think about, do I live in a community that maybe could think about how we support people who are living with dementia? And so this quote, I'll read it for those who can't see the PowerPoint, but this was from a gentleman who was in our group when we very first started. And he said, I try to be a strong person because I am a strong person. But some days you just don't know where you are, not just in this spot, but where you are in the whole world. And this was a gentleman who was in his early 50s. He was 49 when diagnosed, which is very, very rare, but that's what our group focuses on. And I think that speaks to how this can feel. You can just feel disconnected in being a person living with dementia. And so we as Rush, sure, and across the state too, want to think about how we support people who are living with this. And so we've had several paintings made that hang in the Alzheimer's Center, but they were paintings made based on our support group, because we had a chaplain from Rush who was doing her residency to be a hospital chaplain, and she was volunteering with our support group, and she was also an artist. So she drew pictures and then painted them based on conversations that were happening in our group. And this one hangs in our center, and it's called The Pit. And it was because a gentleman in the group I was running, which were people with Alzheimer's disease, he said that to him, Alzheimer's felt like he had fallen into this pit, and he could see everybody back out there, but he couldn't figure out how to get back to them. And so Shauna, for those who can't see it, drew this image of a person down at the base of the painting, and then drew words that were discussed in the group by other people. So things like left behind, lost, disconnected, lonely, isolated, alone, the phrase stay with me. Those were all things that came up and were expressed by people in the group. And I think those all speak to, and especially what the gentleman said about feeling like he fell into a pit, all speak to how this has a profound impact on someone's ability to connect with those around them. And I think we need to see our role as the people, whether we're the family members or healthcare staff, or hospital staff. We have to see our role, or community members of a group, faith community together, see our role of how we help connect. And I think this next this is a little clip from the documentary we made based on the experiences of people in our group. And so this was a couple talking about what Alzheimer's had done to her and how she now felt living with this. And so I want you just to listen to what she's expressing and what Alzheimer's did to her self-esteem.
There are times when I feel like I'm secondary in this family, and that Laura does all the decision making and scheduling, and there are a lot of times where I'm fully capable of it, but I defer to her, and to be honest, I resent that sometimes. It's really hard for me to take a back seat, and that's where I feel like I'm supposed to be, is in the back seat.
So there's times where I feel like, okay, I want to include her and I want to have her as part of this, but it's causing stress to have her as part of that decision because there's things that have to get done and I'll start pushing because we have to get a decision and then it's just causing stress. So a lot of times I'm trying to pull away that stress that she's feeling by just taking care of it, just getting it done.
I don't know, this disease makes me feel like there's a black cloud right over here, and that at any moment it could turn to thunder and lightning, and I'll just crumble.
You know, so that clip really always gets me, and I was there when this was filmed. And for her to say, who looks like if you ran into Pam on the street at that time, you wouldn't have even thought she was living with dementia. But for her to say, I feel like there's this black cloud right there, and I feel like at any moment it could cause me to crumble. I think is really, really sad. And so I think, again, what Dementia Friendly is hoping is that it makes us think about that it's important to
There are
move on to think about how we support and what we do. And so there's two programs that Tricia and I are working with, and it's Dementia Friendly Communities and Dementia Friends. And so the community aspect is thinking about how do we take towns, neighborhoods, areas throughout Illinois and have them think about how they become dementia friendly, what they can do, you know, and it's all steps. It's you know, it's all always working towards it. I live in Westmont, and so I was part of Dementia Friendly Westmont, and we had a whole committee and worked on developing programming, developing ways to reach out to people, to let community members know we existed, to work with our police department. And so if they interact with someone who has dementia, they let us know so that we can provide resources to them. We were having talks at the library, but now a lot of it's on Zoom, and we were doing memory cafes also. So that's looking at the community aspect. And then Dementia Friends, and looking at how as individuals, and that's what we're going to talk a little bit at the end about, how do each of us take on thinking about how do I support someone in my community, and what can I do as just an individual person? Now, both Tricia and I work, you know, we work with people with dementia a lot, but thinking about, for us, how we do it in our personal lives, and what can I commit to in my personal life to support someone with dementia? And so Dementia Friendly Communities is across the United States. You can see from the map, it's in a lot of states. It's in over 300 communities now, and they're looking to expand it into many more. And we are working, we're kind of spearheading the project for Illinois. We're doing it through Rush and with a whole group of other people to look at how we can spread this throughout Illinois, and to keep that momentum going. And I don't know if, is Tricia still there?
Yep, I'm here.
Oh, okay. Do you want to take it? Sorry, I didn't see your image. Do you want to take it over from here? And just let me know when I need to advance.
Okay, awesome. So the screen here, we're talking about the communities that we currently have. So in 2017 was the official kickoff that happened in Springfield. And since that time, we've had 13 communities commit to this effort, which I think is really, really awesome. So we're really proud of that work and everything that's going on in these communities. And there's several more in the process. You can advance, Susan. So next, I want to talk about some of the efforts in Chicago. So as you can see, and those who are on the phone in the city of Chicago, Chicago received ACL community grant in 2019. There's work being done in the senior villages. And there's also dementia training in the high-rise building management. And again, a lot of this is slowed down since COVID, but these are things that have been happening since they joined the Dementia Friendly effort. And one thing that I recently learned about, probably maybe 2 or 3 years ago, that Carter G. Woodson Library, I believe it's in the Washington Heights neighborhood, was declared a dementia-friendly library. And I've had the pleasure of going there and observing one of their programs. It's an awesome library. It's been renovated over the last, I think in maybe the last 2 years, and they have a really awesome space for dementia caregivers as well as the family members and people with dementia. So they offer dementia education services, art workshops, caregiver support, and curated educational material. And they have trained and also dedicated library staff. I'm going to talk about Garfield Park last with another community, but because that's the community that I'm actually working with. But I'll go on to Hyde Park. We've been very impressed with the work Hyde Park has been doing. They are in the process of getting letters of support. They've had seed funding already and awesome community involvement. So they are one of the communities that we anticipate by the close of the year will be a dementia-friendly community. And that's the same for South Loop. South Loop has been providing awesome programming. They have a memory cafe. They had Dance with the Doc. And they're also developing support groups and dementia-friendly presentation. And then the last two communities that I want to talk about are the ones that I have been able to work with directly, which are Garfield Park and Austin, which is not listed because we're still working on getting partnerships. A lot of the work that is being done in these two communities, I've gotten information from the other communities. So it's been really good that although all these communities have a common goal, the path to get there are very different. So being able to sit in on kickoffs and meetings that other communities are having has allowed me to be able to introduce this new initiative to these communities. However, they're in different spaces. I guess we call it like in the pipeline, so they're not quite ready. They have to establish community buy-in. You also have to establish, I said I was muted. Can you guys still hear me?
Yes, we can hear you.
Okay, awesome. Sorry, my screen said I was muted. Community buy-in, and then you also have to have a collaboration with two other organizations to agree to spearhead these efforts. So Austin and Garfield Park are still working on those things, but they are also working on just providing programming while they establish those partnerships. You can advance, Susan. So what you're looking at now is the goal of Illinois in the 13 service areas. So the goal is to support recognition in at least one community in each of the state planning service areas to be a part of the dementia-friendly efforts. And we have some work to do, but we've been doing a pretty good job, and we look forward to having this service and this movement into each of these service areas. You can go ahead and advance. And I believe next we're going to have a movie that's going to talk a little bit about Dementia Friends. So if you guys can listen in to this, and then we'll come back and talk a little bit more about it.
Dementia. Do you know what it means? Perhaps you associate dementia with old age, or maybe it's a term that frightens you. Dementia is not a specific illness. It's a term that describes a wide range of symptoms associated with a decline in memory and thinking skills. These symptoms can become severe enough to affect someone's ability to perform everyday activities. Alzheimer's is a brain disease that causes symptoms of dementia. It accounts for 60 to 80% of all dementia cases. In fact, an estimated 5.4 million Americans are living with Alzheimer's disease. By 2050, the number of people aged 65 and older living with Alzheimer's disease is expected to increase to 13.8 million. It's likely you know someone or will encounter someone living with dementia in your community. At the bank, the grocery store, or a restaurant. Although advancing age is the greatest risk factor for developing Alzheimer's, even those who are younger can exhibit symptoms. Dementia affects each person differently. In the early stages, it may be difficult to recognize someone living with the disease because he or she is still independent and can engage in meaningful conversation. Potential signs include difficulty communicating, getting lost, becoming frustrated, exhibiting confusion, repeating words and phrases, poor judgment, and unusual or inappropriate behavior. Research shows that stigma surrounding dementia can lead to isolation for both those living with the disease as well as their family members. That's why it's so important to better understand dementia and how to help individuals continue to play a role in their community. When encountering a person with dementia, consider these tips. Treat person with dignity and respect. Avoid talking past the person as if he or she isn't there. Be patient and supportive. Let the person know you're listening and trying to understand. Avoid criticizing or correcting. Offer comfort and reassurance. If he or she is having trouble communicating, reassure the individual that it's okay and encourage the person to continue. Living with value and purpose in the community is a human right. Communities must consider ways to make services more accessible for people living with dementia, just as they have made services more accessible to people with physical disabilities. Every segment of the community and every individual has a unique opportunity to make a significant difference in the lives of people living with dementia.
Hey, Mr. Fredrickson, it's Tuesday. Aren't you going to the store?
Yeah.
Come on, I'll walk with you.
To learn more about how you and others can help those living with dementia remain engaged in the community, view our short videos that provide guidance for specific professions at dementiafriendsusa.org.
Tricia.
Yeah, okay. I love that video because it gives real life examples of how each of us can be a dementia friend. I think sometimes, and I know at least for myself, when I first heard about this movement, I was thinking like, how can I really help do anything to help anyone who has a family member with dementia or caregivers? And ironically, I was kind of already doing that. I have a grandmother who's in the late stages of dementia, and I also recently found that my other grandmother's in the early stages. And I've shared some of this information with our family so we can, I guess, all do a small part to make that household, because they both are still staying in their homes, which has also been really beneficial to all of us. We've been able to keep them comfortable in their own homes, but it takes a lot of work. But what we've decided to do is everyone can do a small part. So again, once I first heard about this program, I thought it was something huge that we were going to have to do. And I'm like, I don't know if some communities can actually sustain something like this, but if you look at the small parts that someone can do in the community, then the burden doesn't seem as much. So what is Dementia Friends? So it's a program that engages individuals in this dementia-friendly effort. And you do this by doing a couple things, by raising awareness and reducing the stigma. Now, I will also say that, as they stated before, everyone will not, have Alzheimer's or some form of dementia. My great-grandmother was 97. She never had any issues. So we also, don't want to say that everyone's going this way, but for those who have these issues in their family, we want to be able to talk about it a little bit more. I will say when my dad's mom first got diagnosed, it was kind of almost like a secret because everybody didn't want them to know that, my grandmother was slowly declining, as they were saying. So we want to reduce some of that stigma because what we've done is that we just enjoy her the way that she is. We don't have any expectations on what she should be or what she once was. We understand this is just a change. So we want to raise awareness that just because they're entering into dementia or they have others, Alzheimer's or any other cognitive decline, that there's still life, there's still value to that. My grandmother goes to most of the events in our family. We just still have to have a plan for how that's going to work once she gets there. So we want to, again, raise awareness and we want to reduce stigma. We also want to encourage the adoption of dementia-friendly practices. The video, I think we've probably all seen someone wandering in the grocery store or on the street corner and, not sure what to say, how to approach. The dementia-friendly effort gives you like some tips on how to be able to do that. And then the biggest thing the takeaway for me with this effort is encouraging one action to support people with dementia and caregivers. It can be something, sometimes the only thing, and since COVID has happened, we're not allowed in my grandparents' house now, but something as simple like I may just send a case of water over so they don't have to go out, or I may send food over so they don't have to go out, like just small gestures, or letting someone in your community know that there may be an issue with your neighbor. So just the small things that you can do. So we want to encourage that one thing, that one action that can actually make a difference. And as Susan said, there are a couple ways that you can become a dementia friend. You can join through presentations, and you can also sign up by going online. And then if you have a group that you would like to have a dementia talk, you can also contact me or Susan, and we can get you more information about that as well. Let me go to the next slide. So currently, and again, we would love for anybody who's listening to become a dementia friend today. Currently, we have over 83,000 dementia friends across the country. And we want to encourage people to, again, join us in this effort, tell other people about it, because we want this to be something that is normalized in our communities. We don't want people to continue to live in the lonely space or the isolation, because even when, and a few people have talked about this today with COVID, there's even more isolation. So we're trying to push this effort even more to try to make some connection, because connection is very, very important with people with dementia and other forms of cognitive decline. Next screen. And so here's some more information, the website and the contact information. And before I close, I wanted to actually share a story from a young lady that I'm working with in Austin, where we've been trying to establish this partnership. But since we've been talking, she's noticed like Facebook posts online about seniors who've been missing or who've been wandering. And since we've talked, she's told me she's now directing those posts to other people in the community so they can be on the lookout. And that's kind of what this effort looks like, just being aware. She's not going out and grabbing people or, calling the police or, anything. She's just letting other people know in the community, this may be an issue because these are our elders, our seniors in our communities. So that's also something that, Dementia Friends and the Dementia Friendly effort looks like. So again, nothing, major, just small gestures, and we collectively make a big push. And that's what the movement is about. So again, here are the websites and for more contact information below. And then I believe at some point our contact information will be shared to get more information about Dementia Friends and presentations and trainings. Thank you.
Thank you all. That was great. Susan, did you want to add anything before I move on?
No,
Okay.
we're good. Thank you.
Okay, great. Thank you all so much. That was excellent. All of the presentations were so great. We have a few questions already. For those of you on YouTube, just a reminder, if you're on your phone or tablet, there's a button underneath the video that says live chat. So if you go there, you can go ahead and type a question. If you're on the computer, same thing, but it'll be on the right side of the video. So if you have a question and haven't asked it already, you can put it in over there. And then for those of you on the phone, we will have an opportunity where we'll unmute everyone. And so if you have a question, you can go ahead and speak your question. So let's go ahead and start with everyone on the phone. We're just gonna spend the next few seconds just unmuting everyone. Or if you would like to unmute it on your end and ask a question, this is the time to do so. So does anyone on the phone have any questions?
Okay, I have a question.
Yes.
Okay. My question is that, is there different, okay, I'm getting older but I'm totally blind. Okay, so is there any difference in the, type of care or different type caregivers, or, do you go through, even like medications and things like that? Is there a difference if you have a disability, such as hearing or eye or,
So this is Dr. Mariah. So you bring up a very excellent question. So much of your brain relies on all the input that it's getting. So all of the information from your eyes, all the information from your ears. And so yes, so I can specifically talk about, for example, hearing impairment, and there is a link to cognitive impairment or memory loss. I don't know the specific data for visual impairment or blindness, but it's just important then to kind of hone in all the other parts of your cognition. So, using all the other parts of the areas of your brain and making sure that you set up a safe environment at home. For you, visual cues might not be the best, but you can use audio cues. You can make sure that you have the support system around you, caregivers, people to help remind you of things. But in general, the data, at least for hearing impairment, is yes, there is a higher risk of cognitive impairment. But I would work very closely with your physician to make sure that you're on all the appropriate medications. We want to approach your care as we would anyone, whether or not they have visual impairment.
Okay.
Thank you, Dr. Marai. It looks like there's someone else on the phone with a question. You can go ahead and ask your question. All right, so we'll move on to the questions online. And if you are on the phone, whenever you see an opening, you can go ahead and unmute yourself and ask your question. So moving to our YouTube questions, one participant said, I live in Lakeview. Is there a place near that I could contact to help with dementia patients?
So, and Tricia, maybe you can chime in on this one too. If you're in the Lakeview area, I would say checking in with would be your local senior center. There's also a program called the Villages, which there could be one in the area. I don't know specifically. Tricia, would you know any or?
Not anything.
You know what, your mic is kind of going out.
Sorry. Better?
No. Better.
Okay. No, I don't know anything specific that's going on in Lakeview. If you're interested, that's part of what we're doing is trying to get communities those type of services and resources and connecting them. So I'll be happy to speak with you after offline about bringing some of the programs and services to Lakeview.
Great, thank you. And then the next question, I don't have depression based on the symptoms, but I have a problem with sleeping due to anxiety. What can I do for sleep without taking medications?
Okay, I love that you're asking this question because I think oftentimes the knee-jerk reaction is to have something prescribed, but a lot of the common sleep aids, like Ambien, they actually cause cognitive issues. And so I'm glad you're asking what are ways to address your sleep outside of medications. I think separate from your sleep is the issue of anxiety. This is a very, very anxiety provoking time. I think whether or not you have depression or anxiety, I think a lot of us can say this is just a very anxiety provoking time. So one is the timeline. Is there something in the current events that's making you feel anxious? Or is this maybe something you've been dealing with long term? And so then it's to address your anxiety. If you feel comfortable talking to your primary care doctor, that would be a great place to start. There are medications there for anxiety, but we can also do non-pharmacologic or non-medication approaches. Something like, for example, CBT or cognitive behavioral therapy. It's looking at what are your triggers for the anxiety? What are some of the unhelpful patterns of thinking that you're having that's causing your anxiety? And trying to retrain your thought process, retrain your brain. So if you're anxious about something and you keep repeating that over and over again, it's about recognizing that thought pattern and then changing that dialogue. So that's one approach. It kind of depends on your personal situation. If there's triggers, it's addressing the triggers of the anxiety. This would be a good situation to maybe minimize stimulants like caffeine, because that can make your anxiety worse. I think if you address the anxiety, it will probably also help your sleep. So I don't think it's necessarily addressing the sleep per se, but addressing the anxiety. I would start with just talking to your primary care doctor. I think that's a good place to start. Or if you want to get in touch with a therapist or a psychiatrist, I would focus on addressing the anxiety.
Great, thank you. And then our last question on YouTube, I'm in Arizona. Is there a dementia friend here?
I think there is a Dementia Friends program in Arizona. It's only in 22 states right now, and it looks like Trisha's fast looking it up. But I think there is. And I think there's dementia-friendly communities in Arizona also. So I would go to the website for Dementia Friends and for dementia-friendly communities, and they have contact information that would then send you to the local state contact, which for Illinois, it comes to us. But for Arizona, it would go to someone in that area.
Great. And then could you again repeat the website for Dementia Friendly?
I think it's it's DFAamerica.org, I think is for dementia friendly, or dementia friendly communities. And for Dementia Friends, it's dementiafriendsusa.org. And they will link you to each. So they if you're on one, you can get to the other.
Perfect. And then Teresa, did you? Yeah, go ahead.
And there is a contact for Arizona. So the state lead is on there. So if you go to the www.dfamerica.org, you will see the state lead and a couple of contacts in Arizona.
Thank you. Okay, and then this next question has a medication name, so I'm going to try my best to pronounce it, but I can always spell it if it doesn't make sense. So it says, my husband is taking venlafaxine for depression. He takes several naps each day and wondering if that could be helped with different meds, or is it related to dementia?
So that's, I feel like I would need to get more information to answer that question. However, there's a lot that's probably at play. So when it comes to dementia, oftentimes the sleep-wake cycle is off. And so patients might not be sleeping through the night, and then they feel tired during the day, so they're taking frequent naps. And so I think it would be good to talk to the primary care doctor to see if venlafaxine is the right medication. I'm not sure if that's being what that's being treated for, if it's underlying depression or depression related to the dementia. So I think it'd be good to discuss with a primary care provider. The key that is to try to keep your loved one as stimulated during the day as possible. Try to limit the napping, just so that your loved one can sleep more at nighttime and be more exhausted, so that they can actually get to bed. But the venlafaxine, it likely is not playing a part in the naps, but I think it would be important to talk about the specifics with your healthcare provider.
Great, thank you. And then the last question on YouTube was asking for the contact information or the email addresses for all the presenters today. So if anyone is interested in getting the presentation slides, which does contain that information, you can give me a call. We can always mail it to you if you don't have an email. And if you have an email address, we can email that to you. So if you're interested in any of those materials, you can call me, I'm Jasmine, at 312-942-6995. And again, that would contain the information from the slides today, as well as any relevant contact information you might need. And then before we end, just want to give an additional opportunity to everyone on the phone. If anyone has any last questions, we'll give you these next few seconds to unmute yourself if you're over the phone and to ask a question. It looks like someone unmuted themselves, so you can go ahead and ask your question if you have one. Okay, we'll go ahead and mute that. So it looks like those were all of our questions. And then going back to our speakers, does anyone have any last comments or any closing remarks before we end?
I'll just say that this is a very trying time for everyone. So just know that there is a community to help you out, all of us here and the community at Rush. So please feel free to get our contact information. I'm happy to help.
And I would like to, I guess, piggyback off that. Anyone who has any questions or any, um, I guess, concerns about anything that we addressed today, please let us know. This is a learning process for us all. We're all actually learning to adapt in this new climate. So what we did 6 months ago is not necessarily working today, but we're learning to adjust, and we're very much a part of these communities, and we're all a community, honestly. So we're working together to make sure that, the next 6 months we are in a different place. And thank you, Jasmine, for inviting us.
Yeah, thank you. And just encouraging people to go sign up as a dementia friend. It just takes a few minutes online. So, we're hoping to get as many as we can within the state of Illinois.
Great. Thank you so much to all of our speakers. And just a side note, on YouTube, there's a long stream of comments just saying thank you and thanking you for the presentations. We also have someone interested in becoming a dementia friend, so they're grateful for the information. They said they would love to help. So thank you all so much. This has been received very well. And thank you to everyone who participated. Again, if you would like a copy of the slides, either mailed to you or by email, you can give me a call, 312-942-6995, and we can also get you connected to any resources that you might be looking for now. But a final thank you to our speakers, and thank you so much to our participants as well. Take care.